Have you been told you need to stop doing what you love, whether it's exercise, running, or a sport? Well, here at Dynamic, we don't like that answer. In this podcast, we'll talk to leaders in the health and wellness space from Southwest Florida to get the solutions you need to get you back to doing what you love. Welcome to the Dynamic Naples Podcast. Hey, what's going on? It's Dr. Chris here. Today I have something a little bit different for you guys. I recently took a course called Primary Care PT through PT on Ice, an excellent course. And we had a final project we had to put together, so I made this presentation on diabetes. It's called The Clinical Implications for Diabetes. And this is my recording of the actual video. So if you're already watching this on YouTube, you can click on the link in the show notes. There's going to be the actual presentation if you want to follow along with the slides. I did record this in chunks, so the audio is a little bit funny at times, but the message still works. So without further ado, here we go. Hey, what's going on? I'm Dr. Chris. I'm a physical therapist. I'm in Naples, Florida. I'm owner of Dynamic Physio. And I put together this presentation both for my clientele and also for any new therapists I hire. I'm actually very passionate about diabetes because I was born with hypoglycemia, which basically sets you up to become diabetic later in life if you're not careful. So I've always kept a tight eye on my blood sugar regulation, and I feel like this is important more now than ever for most Americans. So here's what we're going to go over today. I'm going to talk about the magnitude or just how big of a problem this is, which is huge. So with that, we'll go over the history and prevalence. I'm going to spend a lot of time with that because understanding how we got here I think is vital to understanding nutritional guidelines and how maybe not all the guidelines are exactly right. We're going to go over some complications from diabetes and some orthopedic considerations. Then we'll talk about measurement, so recognizing clinical signs, some tests that we can do, and some other tests that can be ordered, and we'll go over some blood markers. And lastly, we'll talk about how to manage diabetes, what to do in a hyperglycemic or hypoglycemic event, and then diet and lifestyle recommendations to manage diabetes. So now we'll dive into the magnitude. So we'll start off with the history and something I like to call the perfect storm. So there's a few key players and events that occurred that led to ultimately the formation of the diet-heart hypothesis. That's sort of the current hypothesis. This is the basically the idea that LDL is bad and clogs the arteries. So a lot of events occurred to lead to this, and we'll start going over that. So in 1955, President Eisenhower had a heart attack and left him basically bedbound for about 6 weeks. And a heart attack at this point was not common, not like it is today. So the country kind of had a big scare. So around this time, there was a physiologist by the name of Ancel Keys, and he noticed a trend of middle-aged businessmen having heart attacks. And he came up with the theory that saturated fat is what clogs the arteries. So he set out to prove this. So Keys proposed the diet-heart hypothesis to the World Health Organization and eventually the American Medical Association, who adopted it. He then went on to do what's called the 7-country study. This is a very famous study, and it's, I want to say biased, but it's observational research, first of all. So observational research or epidemiology has some issues. It's basically correlational research. So you've probably heard the phrase correlation is not causation. And that's true because you can pick like any two variables and put them against each other and you can find some sort of correlation. And these are fun to kind of Google. Here's one I found. The number of people who drown by falling into a pool correlates with the number of movies Nicolas Cage has been in. Or how about this one? Per capita cheese consumption correlates with the number of people who die by getting tangled in their own bed sheets. Kind of a crazy one, but point being is that the 7-country study was an observational study. Generally, when you're doing these types of things, and in nutrition science in particular, it's very hard to do research on, but you start off with that correlational research to see if you can find a signal. Then you have to go on and do like randomized controlled trials and other high-level research studies to basically figure out if your hypothesis is correct. So that's problem number one with the 7-country study. Problem number two is what's called healthy user bias or unhealthy user bias. So that basically just means that if you were making conscious decisions about your health, say you went from a standard American diet and said, you know what, I want to get healthy, and then you decide to go vegan. Well, you're also, that's like a keystone habit. You're also going to tend to do other things like move more, exercise, and just make better decisions around your health. And the converse is true, which would be the unhealthy user bias. So if you're one that kind of takes risks and chances and maybe ignore dietary guidelines and eat a lot of red meat and smoke cigarettes, you tend to get some unhealthy variables. So this kind of puts a lot of variance into the signal and damages any kind of validity. But the third and probably biggest problem with the 7-country study is that he did do observation of 22 different countries, and he only picked the 7 countries that fit his hypothesis. So saturated fats took a hit from the 7-country study and the work of Ansel Keys. And meanwhile, on the other side of the coin, sugar, the big sugar corporations, were basically plotting some things. So they had the SRF, which is the Sugar Research Foundation, and that was headed by Henry Haas. And he said that if they could recapture the fat consumption of Americans and repurpose it as sugar consumption, they could increase their profits by over a third, which is very profitable. So then the SRF went on to basically bribe some researchers at Harvard. They paid them $50,000 to sponsor some research and had them say that basically saturated fats are to blame and sugar does not cause any heart disease. This is all open access. You can find all this information on the internet, and it'll be in my references as well. Oh, I should mention that research was in the New England Journal of Medicine, and back then they didn't have the conflict of interest disclosure. That wasn't a rule back then, so it was not clear who funded the research. So it was basically a double whammy. That's why I call it the perfect storm, like a rogue wave. On one side you got researchers saying that sugar is not to blame, and the other side you have Ansel Keys saying that saturated fat is to blame. And fast forward, you have the fat-free craze that hit the 80s, and now, diabetes is insane in this country. And so diabetes is insulin resistance, basically the same thing. Insulin has a crucial role in the body. All our cells have insulin receptors, and it has, you're probably familiar with the idea that insulin pushes sugar from the bloodstream into muscle and liver, but has a lot of other roles. And one of the main roles it has is an anabolic. It's a builder of things. So it does build fat cells. In fact, diabetics who regularly inject insulin develop these sort of pockets of fat right at the injection sites because of all the insulin. So that's the perfect storm. So let's go over some numbers here. So type 2 diabetes prevalence. Well, first I wanted to say this is what I call the diet spectrum, right? So there are 3 macros. We've got proteins, fats, and carbs. So everyone agrees that we need protein. There's nothing controversial about that. But the controversy sits in, is it carbs or fats that are making us fat and sick? So if you picture a spectrum, we'll say on the left side, so arbitrarily, you've got a high-carb, low-fat diet. So that's going to be vegetarians, vegans, the whole plant-based movement is going to be in the high-carb, low-fat diet. And then the opposite side, on the right side, you got high-fat, low-carb. So on the very extreme, you got carnivore. Then you've got, paleo, Atkins. Those are all on that side of the spectrum. So you're thinking around which macronutrient is the devil, in a sense. Hint, neither one are, by the way. Will determine which way you are veering on the spectrum. And let me clarify, too. When I say carbs, I don't just mean breads and pastas. I mean glucose. So, fruits and vegetables are high carb. And again, that's not necessarily bad. There's not all carbs are equal, but I just want to point that out because people just think carbs means breads and pastas only, and it's not just that. So currently, 1 in 3 Americans has prediabetes, and of that group, of that 33%, 84% of them don't even know they have it. It has not been diagnosed. Even worse, childhood obesity is just skyrocketing, and it has been since the 80s. And so one of the things I hear often is, well, I can't afford to buy high quality fruits and vegetables or go to farmers markets. This is where I like to bring up this number, that the average cost of care for someone who's diabetic is nearly $17,000, which is 2 to 3 times more than the average person. So it's where do you want to pay? You want to pay more and be sick, or do you want to pay a little bit less and be healthy? Now we'll move on to some of the complications from diabetes. So first of all, insulin resistance causes the majority of the issues that we deal with as Americans. In fact, there's a great book called Why We Get Sick by Benjamin Bikman, that's Bikman, and he really spells out all the things that insulin resistance does to us. But I just picked out some that physical therapists will tend to see and have some clinical implications. So first up is high blood pressure, hypertension. So insulin, when it's behaving normally, suppresses inflammatory markers in the bloodstream. And it also stimulates nitric oxide production, which is a vasodilator. So if insulin is no longer doing its job, or I should say the cells are no longer responding to insulin, it has the opposite effect. So if you picture a hose, it's kind of getting shrunk from the inside out because those inflammatory markers are allowed to stay there and fester. And then you also get like constriction of that tube because of the lack of nitric oxide production. So it's like a double squeeze, and that's what causes high blood pressure. Now, obesity, so I think a lot of people think that obesity causes diabetes. I kind of see it as the other way around. It is a bit of a two-way street because once you are obese, it does create a lot of inflammation in the gut. But generally, it's the insulin resistance is what causes it, because then your pancreas has to secrete more insulin to deal with any sugars in the blood. And as I stated earlier, insulin is an anabolic and can help build fat. It's a little more complicated than that. There's other hormones involved too, like leptin. But that's the general principle. I mean, we basically want to stay insulin sensitive. So salt is often blamed for high blood pressure, and it's not quite accurate. So it's really sugar is the issue, and salt kind of takes the blame. Salt is sort of the fall guy. So aldosterone, first of all, your kidneys are always balancing your water to electrolytes, which are your waters and salts. Aldosterone is a hormone that communicates with the kidneys and tells it to hold on to salt. And when you become insulin resistant, that increases aldosterone production. So really, the sugar is the main issue. That's the one that causes fluid retention in the first place. Okay, lastly, Alzheimer's, or what's called type 3 diabetes. Have you heard that? That's a term now. So high levels of insulin cause the nerves to release an amyloid beta protein. That's the one that's implicated in Alzheimer's. So Hippocrates famously said that all disease begins in the gut, and that's another just perfect example right there. Okay, so now for some orthopedic considerations here. So arthritis, okay, this is kind of a fun one to me. The wear and tear model, I call it SAD and poor, not wear and tear. SAD as in standard American diet, and poor mechanics, as opposed to your classic, that you're just beating up your joints. It goes against a lot of the principles of physiology that we know. There is Wolff's Law that a body will respond to the stimulus put into it or not put into it. Right? This is why astronauts come back from space with osteoporosis. And this is why runners have more cartilage in their knees than sedentary folks. We know that just a 10% decrease in body weight will reduce the breakdown of cartilage. And, you could maybe make the argument that has to do with less compression on the joints, but I think it has more to do with the inflammatory effects of something like diabetes and fat cells that do increase, like cytokines. Also, we know that diabetics with high glucose concentrations are at risk for early onset arthritis. And the other thing, too, is that sugar is sticky, which is the process of glycation. It sticks to proteins. And sticks to the proteins in the cellular matrix of collagen and the cartilage and helps accelerate degeneration. So for muscle, the tone of the muscle is dictated by your nervous system. So, we hear this a lot as physical therapists. I hold all my stress in my neck. It's like, well, you're stressed, so your muscle tone is upregulated, basically. So you have two sides of your autonomic nervous system. The sympathetic, which is your fight-or-flight, and the parasympathetic, which is the rest and digest. And it's not like you're either one or the other. There's a gradient to it. So if you are in a sympathetic state, literally your nervous system will increase the muscular stiffness to prepare you to either run or get into a fight. And the sad reality is that most of us are chronically in a sympathetic state. I learned this when I wore a continuous glucose monitor for a month. And it's a good proxy to tell you what state of mind you're in, because when your sympathetic nervous system is activated, cortisol, the stress hormone, is released, which basically liberates the glucose from the muscle glycogen and liver to get it into your bloodstream, because it is a great fuel source to prepare you for fight or flight. So if you wear a CGM, you can see in real time what your blood glucose concentration is. So if it's high, you know you're in a sympathetic state, especially if you haven't had a meal. So I noticed that every single time I drove, my blood sugar would be near diabetic range. And part of that's gaze related too. So your gaze is tied to your nervous system. So when you have a fixed or concentrated look, you're more of a sympathetic state, as opposed to using your peripheral vision. So picture like looking at a horizon or the beach or something like that. That's really relaxing. That stimulates the parasympathetic system. So some of these things are just meant to be this way, but the truth is that our modern lifestyles are very sympathetic. Even just like looking at a phone at night, you're in a sympathetic state. That's why it's hard to fall asleep, not to mention the blue light. So if you're in a sympathetic state and you're dealing with some muscle pain, it's going to be really hard. It's kind of like fighting against a current. And I think that's the main reason massage works, by the way. You're just accessing your parasympathetic state, allowing the muscle tone to calm down. It's not breaking up scar tissue or something like that. Okay, next up we have measurements. So let's move on to recognizing some signs and symptoms. So a couple of these I didn't know until I started diving into this research. Skin tags, which is just a protrusion of skin, tends to be around the neck or armpits. That's a sign of prediabetes developing. Or this one, acanthosis nigricans. I've probably seen this on generally on more obese patients. They're going to have a thickening and a darkening of the skin, particularly in the neck, armpit, and groin. Obesity, obviously, we've talked about that one already. And hypertension, in fact, Benjamin Bickman says if you have central obesity and you have high blood pressure, you, by definition, have at least prediabetes. Okay, so let's get into some of the tests and measures. So one test that anybody can kind of do to themselves, and physical therapists, we can administer this as well, is a glucometer. So glucometer looks like that little icon in the blue slide there. It's it's a finger prick test. As a therapist, if you're going to administer this, you have to sign a CLIA waiver first. That's CLIA, CLIA waiver. All right, these can be purchased online, Amazon, most pharmacies, Walmart. Walmart has one called Rely on Prime that's cheap. I think it's like $15 or $10. And you're looking for a fasted glucose that ranges between 70 and 100. It depends on the lab and depends on if you're talking about traditional lab values or if you're talking about functional medicine values. And then a postprandial, so after a meal, glucose should be under 140. That's considered normal. Once you go above 40, it's prediabetes and then into diabetes. So these are really easy to do. If you can give a patient or instruct a patient to have a food log, and they can track their 1 and 2 hour response to a meal using the glucometer. Some other tests, there is an OGTT, that's an oral glucose tolerance test. That's where they drink a solution of, I believe it's 75 grams of something syrupy, sugary, and they look at how their blood sugar responds. If you do have diabetes, that can be kind of a pretty nasty test to take. Glycomark, the idea here, so A1C, which we'll get into in a minute. A1C is a standard blood test that looks at the average of blood sugar, the amount of sugar that's been glycated to red blood cells. So you get a 3-month average from that test. But the idea with the glycomark is that you don't see excursions with an A1C test, whereas a glycomark will be able to see the big swings in blood sugar. CGM, that's what I usually recommend to my patients, one of my favorite tools. That's a continuous glucose monitor. Those are the ones that look like a little disc that you wear on your tricep. You can wear it for a month or more, and many of these companies will have an app that comes with it that gives you real-time data about how your blood sugar responds to food. And you get great insights to it too. You can see how exercise, stress, sleep, all these things, how they affect your blood sugar. And then lastly, what I think is a very valuable tool, and I think as physical therapists we should have a bigger, greater understanding of blood work. We'll dive into that now. But first, let's do a quick review of how insulin and blood sugar work. When you eat some food with some carbs in it, Sugar is in your bloodstream, and then your pancreas recognizes that, and then it pushes insulin into the bloodstream to usher the glucose into your liver and into your muscles, mostly into the muscles. That can be impaired over time, especially as we age. And you can even get what's called beta cell death. So the beta cells are in the pancreas, and those are the ones that secrete the insulin. So over time, if you kind of ignore being pre-diabetic or becoming diabetic, those beta cells stop producing as much insulin, and then you have to become insulin dependent. So it's irreversible at that point. But if you catch it early, you can do something about it. So that's what I want to go over. So I'm just going to sort of list the primary and secondary markers that you'd get on if you had like an in-depth blood panel. You got glucose. So I'm going to talk about two, high or low, what pattern we're looking for things to be out of whack. So glucose would be high. Hemoglobin A1C or HA1C would be high. Fructosamine high. Post-meal glucose high. Triglycerides and LDL high and HDL low. So your cholesterol does play into your metabolic profile. It's really important to know. And then some secondary hyperglycemia markers would be uric acid, which would be high, a fasting insulin high. And then your liver enzymes could be high. So that'd be ALT, AST, GGT, and LDH. So those would all be high. So basically all of them besides HDL would be high, whereas HDL's inverse marker would be low. So let me talk a little about glucose. So you see the lab ranges can go up to 94, 97, depending on the lab. Functional medicine will tighten that window to kind of catch things before it happens. So functional range in the course I'm taking is 75 to 85. It is the least sensitive marker for blood sugar dysregulation. And that's unfortunate because it's kind of the standard one that's used. So, glucose basically only tells us about how blood sugar is in a fasted state. And also to keep in mind that stress, lack of sleep, certain drugs, these can all alter your glucose. So you can get a lot of bad reads. So let me go into a little more depth on that insulin release I was talking about. There's actually two phases. So when you first eat something, when things are working right, you have a first phase response, and that should return your glucose under 100. And if it doesn't, the pancreas kind of pauses, and then 10 to 20 minutes later, there's a second pulse of insulin that's released, and that should return below 100 in a normal person. When that whole process is impaired, usually it's that second phase response that worsens, and that can take up to 4 to 5 hours to restore your blood sugar down to normal. So if you are pre-diabetic and this is happening to you, during the day, you may never have normal glucose because of meal timing, especially if you snack a lot, or you're doing the 6 meals a day type of thing. So the only time that your glucose might be normal is in fasted states, or such as like first thing in the morning. So because that can lead to a lot of false positives. It does go out of whack at a certain point. So it's a decent rule-in test, but a pretty poor rule-out test. And there was a study actually in China where they found patients with dementia, because there's a correlation between dementia and blood sugar dysregulation. In fact, type 3 diabetes is basically from glucose dysregulation. They found that in the study, over 80% of the patients with dementia had fasting glucose over 90. So that's still in the the lab range normal. That's in the higher end, but still considered normal. So that just kind of opens your eyes to, okay, well, some of these markers, maybe their ranges aren't quite right. Okay, hemoglobin A1C. So the functional range, 4.6% to 5.3%. So what that is, so sugar is sticky and it sticks to your blood cells. It sticks to the hemoglobin molecule in particular. So that's called glycation. So red blood cells live an average of about 90 days. So this is where there's a strength. There's some weaknesses too. A1C, it's really a measure of, it's like a 3-month average, basically, because of those 90 days. So it's got that say you're 5.3%, 5.3% of your red blood cells have been glycated or have sugar stuck to them. So it's a little better than glucose, because glucose is kind of just a snapshot. However, there is variability in blood cell lifespan. So some healthy individuals, their blood cells can live for over 146 days, whereas diabetics, their blood cells lifespan can be like 81 days. So what that means is that A1C can be low in diabetics and vice versa. All right, so that kind of clouds the whole thing. There is another marker that I didn't mention yet called MCV, which means mean corpuscular volume, and this can be used to kind of tease out the A1C issue. So what that is there's variance in your blood cell sizes, right? So they're born big and die small, kind of opposite humans, right? So in other words, a high MCV can mean short-lived blood cells, and a low MCV can mean long-lived blood cells. So if your A1C is high and MCV is low, it could mean that A1C is high due to long-lived red blood cells. So it's an inverse marker. So that can help tease out any issues with your A1C. Now, fructosamine is another marker. So when this goes out of whack, it's high. It's another average marker for blood sugar. So you have proteins that float in your bloodstream, such as albumin, and those get glycated by sugar too. But these proteins only live for about 14 to 21 days. So it's really a measure of blood sugar control over 2 weeks rather than 3 months. It's a cheap test. It's precise. You don't see it often, but it's a good one to get. Probably more accurate than A1C, and it's probably free of interference from some of the blood disorders like anemia that can affect A1C. The only problem, though, is it hasn't been standardized yet. And then the most sensitive marker for blood sugar dysregulation is post-meal glucose, if that's high. There's a number of ways that measure this, and this is the best way to find out where you stand. Okay, let's move on to management of diabetes. So what do you do in an emergency situation when someone's having an event? So we'll start off with hyperglycemia. So some of the symptoms of hyperglycemia are going to be dry mouth, thirst, weakness, headache, blurred vision, and frequent urination. And this is usually if their blood glucose is greater than 250. And this is also known as DKA, diabetic ketoacidosis. So they should go to the hospital, and they'll be given fluids and insulin. If they have insulin on them, it should be administered. Symptoms of hypoglycemia include sweating, pallor, irritability, hunger, lack of coordination, and sleepiness. And this is when their blood glucose can drop below 70. This could happen in a fasted state. They could have reactive hypoglycemia when they've had a meal and they suddenly crash after that. That's reactive hypoglycemia. So for them, the risk is a diabetic coma. So you want to give them something sugary. So food or drink of 15 to 20 grams of fast-acting carb. That could be like orange juice, some sort of gel or fruit juice, honey, sugar. If you give them soda, that's okay. Just don't give them a diet soda because you want them to have the sugar in that event. So that's what you do in an emergency situation. So what about some diet and lifestyle changes you can do? Well, the first thing is you want to recommend more protein. First of all, most people are protein deficient, unfortunately. But protein, and particularly if you do it for breakfast, has a stabilizing effect on your blood sugar. So you want about 25 to 30% of your calories, of your daily calories from protein. And a general rule of thumb is 1 gram of protein per pound of goal body weight. Now, that's kind of a lot. So I'd say at a minimum 0.7 grams. That's what the literature says. But if you can shoot to 1 gram, that's going to be better, and it really depends on their goals. Another one is to eat more fermented foods and fibers. So poor gut health, it can contribute to poor metabolic health, and resistant starch is particularly useful for improving insulin sensitivity. All right. Another thing is altering your food intake timing. So something like fasting will force your body to sort of soak up and use all the carbs in the system, and then run the backup generator, meaning you start to use lipids and fats for energy. And this also has the advantage of improving your insulin sensitivity. So a good idea to not always be spiking insulin. Physical activity, this is an obvious one for us as physical therapists. It's got a number of beneficial effects on blood sugar. Improves insulin sensitivity, and it also, when you use your muscles, it's like a sponge. It pulls sugar into the muscle, so you can literally soak up some of those blood sugars. We've all heard the 10,000 steps a day thing. I mean, with a lot of my patients that are diabetic, they're, lucky if they're doing 3,000 steps. So obviously progress as tolerated. So if they're doing 3, maybe 3,000, and shoot for 4,000 steps and just progress from there. You want about 150 minutes at least a week of moderate activity and 75 minutes per week of vigorous activity. Okay, sleep is a big one. 7 to 8 hours is the general rule. That's going to vary a lot for some people. Some people are biurinal sleepers, so some people do better with a nap in the afternoon. But if you ever wear a CGM, you'll see this. If you do like 5 or 4 hours of sleep, your blood sugar is going to be very elevated that next day. It basically puts you in a pre-diabetic state. Some rules with this: you want to keep it cool. Keep the bedroom 68 degrees or lower, and avoid blue light. Blue light kind of resets your circadian rhythm and throws sleep off dramatically. There's a great TED Talk by Matt Walker. He's a neuroscientist who studies sleep and its impacts on health. And one of the things he mentions that's fascinating is that in the spring when we change our clocks and lose an hour's sleep, there is a 24% increase in heart attacks that following day. And conversely, in the fall, when we gain an hour, we see a 21% decrease in heart attacks that next day. So pretty important stuff here. Okay, lastly, we have stress management. This is kind of an easier said than done type of thing. Stress is a big factor in Western society. As I mentioned earlier in the presentation, when you're in the sympathetic state, cortisol is released. That increases your blood sugar. And how many of us are in a chronic sympathetic state? So I always tell my patients to seek parasympathetic activity, and there's a lot of ways to do this. So meditation, Tai Chi, yoga, deep breathing. I'm a huge fan of breath work. Breath work is so powerful, and the amount of people that breathe sort of paradoxically is like an epidemic. So that to me is an easy one, because if you think about how many breaths you take a day, it's a big return on investment, and it's free. So I just want to touch on this again, the impacts of exercise, right? So there's kind of three ways we can use exercise to reduce blood sugar. First off is if you're doing something like HIIT training, something more vigorous, your body's going to prioritize carb consumption, carb usage, whereas if you do like steady state or something slower, you're burning more fats for energy. Secondly, it's important to note that there are two pathways where sugar leaves the bloodstream and goes into the muscle and liver. One is the insulin pathway, and then there's also the non-insulin mediated pathway. So this is what I was talking about on the previous slide, that when you use your muscles, it just draws sugar from the bloodstream into the muscles. And lastly, we have fasting cardio. I already touched on that before as well. But I will just point out that although it's a useful tool to use, it should be used sporadically. That is a form of stress in the body. I see a lot of people doing fasted cardio every day, and that can be really tough to recover from. So use it, maybe once a week, once a month, depends on the condition of the client. The advantage there is that so many of us get used to burning basically carbs for energy all the time, and we become inflexible. We kind of our bodies forget how to use fats, so it's kind of good to be able to go back and forth from carbs to fats. So it's a good kind of assessment and a strategy to improve metabolic flexibility. Okay, that's it. That's the end of this presentation. I do want to reiterate that I really believe that physical therapists should be at the forefront of this diabetes epidemic. We have the time, we have the skills and the knowledge. If you have any questions about this, please feel free to reach out to me. I've also got a bunch of references here on the slides, and I will put those in the notes. Why guess when you can test? Do you get hangry or crash after a carb-heavy meal? These could be indicators that there is a dysfunction in your blood glucose regulation. If left unchecked, it can lead to irreversible changes. If you catch it quick enough, you can make diet and lifestyle changes that will get your levels where they need to be. 88% of Americans are pre-diabetic and don't know it. Diabetes underpins many of the pathologies we deal with in this country, such as obesity, high blood pressure, heart disease, and stroke. For some reason, it is rarely screened with your physician, and if they do test for blood glucose, it's usually with an A1C or a fasting glucose, which can sometimes give you a false negative. NutriSense is a company that supplies continuous glucose monitors. We've paired with NutriSense to get you real-time data to see how your physiology responds to glucose. The NutriSense app lets you track your daily activity to see how food, sleep, exercise, and stress impact your glucose. You can log or import this data into the NutriSense app to see the effect on your blood glucose levels as soon as it happens. Use the code DrChris25 for $25 off your order today. Do you have unexplained pain, or do you wonder just how healthy you are? When was the last time you had your blood tested? Blood chemistry analysis is a great tool to stay ahead of any health conditions, and now you can have control of your health with Let's Get Checked. Let's Get Checked is an incredible company that sends blood tests to your home. You can choose from over 30 different tests, whether that's thyroid function, testosterone, micronutrient, cholesterol, or C-reactive protein, which is a marker for inflammation. It is sent to you with free shipping, and you get results in 2 to 5 days. No physician referral needed. Use the code DPT25 for 25% off. You can find links in the show notes. Did you know that you can get started with physical therapy without a physician's referral? Physical therapists don't just solve pain, we get down to the root cause and keep it from coming back. We also discuss all things health, such as nutrition and lifestyle changes. If you feel that you could use some help, let's get on a free consult call. Go to www.dynamicnaples.com and sign up for a free call. Also, if you like this podcast, please give us a rating wherever you listen to podcasts. It helps us spread the message. Thanks for listening, and we'll see you next week.